always right. I gave you guys a little bit longer break because some of you guys, woo! I'm like, man, we gotta get the AED, get the crash cart. All right, how's everybody doing? Woo! Yeah? All right. I seem to always get you guys when you're like super energized. I appreciate the effort to it. Okay, so before we get too far into it, hopefully yesterday's lecture, while you were drinking your coffee, I know it was coffee, Tippet. So, or no, Tate, the other tea. He decided not to come. Never mind. He had too much coffee. So before I get too far into it, I wanted to make sure I covered spasmodic torticollis. I know I talked to you guys. I didn't want to go into it before the test, because then you're like, oh my goodness, now I got a whole other thing to remember, right? So spasmodic torticollis is a neurological condition that causes involuntary painful spasms of the musculature of the neck, right? So that the patient can have kind of a ticking, and then if it's in a locked position, then that's when you get into like Botox treatments and things like that. Okay, but spasmodic torticollis is not a form of acquired torticollis, and it doesn't like this part of the room. All right, I'm just going to stay over here the rest of the time. All right, so but it is not acquired torticollis, so that's why I didn't want to throw that in the mix before the test, because you're like, wait, what is that, right? So acquired torticollis again is those congenital anomalies that are numerous, right? So acquired torticollis is something that, are you guys going to hang on to that, or are you going to refer that? Refer, right? CMT, congenital muscular torticollis. You'll do the therapy stuff, not you, right? You'll send them to the proper therapy, and if they don't improve within how many months? 12? Okay, 6. Okay, perfect. You guys took the yeah. You guys took the test, and you're like, whoop, there it goes. All right, but they should get better within 6 to 12 months, okay? So if they don't, then you'll send them to see some specialists as well, okay? Any questions about torticollis before we move on? No? Okay. All right, as I told you guys yesterday, I hate virtual lectures because I can't really get into like some of the physical exams and really the nitty-gritty of some of these diagnoses. But, so I held off on trochanteric bursitis because this is really when we start talking about some physical exam stuff and some kind of differential diagnoses. So going right into it, trochanteric bursitis, so we talked about the greater trochanter and the lesser trochanter, right? So this one specifically, is this the lesser or the greater? So this is lateral, this is lateral hip pain, right? So lateral hip pain, not anterior hip pain. If you have anterior hip pain, what's your main thing you're going to ask the patient? Right, they're going to stand there like this, the C sign, right? Is the pain deep inside the joint, right? So that's what you're going to say. So now we move on to lateral hip pain. Okay, trochanteric bursitis, inflammation and hypertrophy of the greater trochanteric bursa. Okay, so what that basically means is they should be able to take one finger and put it right on the greater trochanter. So if they're doing this, then you're like, I wonder if it's that. Okay, does that make sense? Causes, numerous. Okay, too many to list. But inflammatory arthritis is on there, right? So can patients that have rheumatoid arthritis have a high incidence of trochanteric bursitis? Yes. Can patients that have psoriatic arthritis have greater trochanteric bursitis? Yes. So it's important to understand that some predisposing conditions can lead to that. So if you look at the picture, it's clearly labeled, the structure that we're talking about, and that's the bursa. Don't worry about the blue bursa. You're worried about the red bursa. Okay? Now, you guys know that there's bursas all over your bodies, right? A lot of places. Well, the ones that I tell you about and we've discussed, those are testable. Okay? So then, we talked about greater trochanteric bursitis, so very focal pain. The patient's doing this, right? It's pointing right here. But then you have another condition that kind of goes, not necessarily with it, but greater trochanteric bursitis is actually part of it, and that's greater trochanteric pain syndrome. So see how if you look on that list there, it's all otherwise known as GTPS in case you see it abbreviated. I don't abbreviate things on my test, right? I don't try to confuse you guys. I just want you to know if you see that in a chart somewhere and you don't walk to the middle of the room, then That's what they're referring to, okay? But see how trochanteric bursitis is part of this syndrome, right? So, but the big thing too is that they can have gluteus medius and minimus tendinopathy, okay? And we'll talk a little bit more today about some physical exams when you're talking about weakness of the gluteus musculature, okay? And we're going to talk today about iliotibial band syndrome, okay? Or iliotibial syndrome, sometimes it's called iliotibial band friction syndrome. There's like 7 different names for it, okay? But again, the syndrome is a constellation of symptoms. Do you think that somebody comes in and they point to their greater trochanter, but then they also say they have pain in the buttocks, right? They have pain on their lateral thigh, more distally, that you have to start thinking about GTPS and not necessarily just greater trochanteric bursitis. Because greater trochanteric bursitis is a very focal treatment, and then those other components of it have to be treated as well. Otherwise, do patients come back? Yes, whether you want them to or not, okay? So, clinical symptoms, lateral pain, question mark to the knee, okay? Now you guys are going to start hearing me say this very commonly. Hip pain can be knee pain can be hip pain can be buttock pain can be knee pain. It's kind of a continuum, right? And that's because we know that certain musculature spans both the hip joint down to the knee joint. So it's important if you're talking to a patient about hip pain, you know, that you ask them, do you also have knee pain? And we'll talk about that differential diagnosis today, okay? Again, talking about trochanteric bursitis, it's important to understand and ask them, do you have any buttock pain? Do you have any knee pain? Okay, because then you get into that gluteus medius minimus tendinopathy, and don't just ask them about that one symptom, okay? Pain with first motion after being in a seated position or laying down, and it lessens after a few steps. So basically they have the pain. As they move, the pain tends to lessen. Does that make sense? Okay, so clinical scenario-wise, you may see something like that presented. And then when they have pain, it can be more significant over 30 minutes of exercise. The other thing is, if the bursa is compressed, do you think they have pain? Yes. So if they sleep on their side, right, they're a side sleeper, and they say that they sleep on the affected side, then that's something to take note of, okay? I don't know what I do. I just stay up here, I guess. All right. I hate it. So physical exam-wise, again, greater trochanteric bursitis, they have pain there at the greater trochanter. That's actually called a test. Seems pretty straightforward, right? But it's actually a test. If you push there, it hurts. Okay, what's another test that's on that list? Pain with resisted hip abduction. So away from the midline, correct? So they're resisting, they're on their side normally, and they're resisting abduction, abduction, okay? And then we start getting into the Faber test, okay? It's also called a figure 4. Why? Because it looks like the patient's in a figure 4 when you're doing it, correct? And just to confuse you even more, I'll stop myself, it's called a Patrick test. So don't get confused with that. If you see in the bottom right there, it tells you that all those tests are the same test. Okay, and we'll get into that more so, excuse me, in our lab. You guys, to my understanding, you guys have done Faber tests, correct?
Yes.
Okay, maybe you haven't done the resisted abduction test, but we'll get into that again. GTPS, so you want to check for what? The positive gluteus medius and minimus tendinopathy, specifically pain and or weakness, okay? Ober test, did you guys do Ober test in clinical skills?
Yes.
You did, okay, so you understand that the Ober test is testing to see if they have IT band tightness, right? So that's something you're going to do in conjunction with this, because did we say that IT band pain goes with GTPS? Yes, so if it does, then you have to test for it, correct? Okay. Any questions at this time about these special tests? Don't worry, we'll get into it with the lab. Okay. If you haven't looked at these tests in a while, maybe just take a glance at it before the lab so you're a little more prepared. Okay. Okay, so this is it. I made its own slide. If it has its own slide and it's not marked FYI, Do you think it's something I want you guys to know?
Yes.
Yeah, she said whatever. Okay. Yes, the answer is yes. So Trendelenburg sign, you need to know it. Okay, this is different to Trendelenburg gate, correct? The answer is yes. Okay, Trendelenburg sign. So you're going to have the patient like this, correct? Have you guys done Trendelenburg sign yet? You have. Okay. So when I describe that test to you on an exam, you need to understand what a positive finding is. Okay. So if the patient has the weight bearing on the left side, as denoted in this picture, and the hip drops to which side? The right side, right? So they call it the stance leg. The stance leg basically means that the stance is being supported by the unaffected side or the affected side. Okay, so that's what I want you guys to think about. Okay, so obviously there's no resounding answer there, correct? So what I want to tell you is you need to understand this concept. When you have the patient stand on their left leg, like it's seen on this picture, and their hip drops to the right, the musculature is not able to support the stance, correct? So therefore, it's positive for right-sided weakness. Does that make sense? Yes? I hope so, because I'm going to ask you that question very soon, right? And someone will get it wrong. Please don't. I don't want you to get it wrong. But I just want you to understand that this very commonly people say, well, the left leg is the one that they're putting the weight on, so it's positive for left-sided. Okay, and that's not correct, is it?
No.
No? Okay. All right, good. So do I need to go through this a little bit more? Any questions for now? Don't worry, we'll go through the lab. It's just good fun to poke fun at people, right? Especially people in previous classes. Yep.
So if it's right-sided, so if they start standing on their right side, will their left side be normal then?
So in this picture here, the abnormal pelvis tilts from the stance leg, right? So that's why I presented this picture here. Okay, so what I want you guys to do, and what he's asking is, he's basically asking the opposite, okay? What I want you to do is learn one side, okay, for now at least, and that way when you think about it during the test, then you can be like, okay, so if their stance leg is the left and the hip drops on the right, then the abnormal pelvis tilts away. Did I answer your question?
Sure.
Yeah, sure.
So for the future.
The left is the one that's not doing what it's supposed to do. So if this same person that has that abnormality this way,
Yeah.
if they stand on the right foot, would it be normal?
Yeah, would it be normal? So
So if they were to, this person on the right side picture, who has that right foot drop, was to then put their right foot down, would their left hip drop, or would they be able to compensate, or not compensate?
well, they're not putting any weight, right? They're not trying to so that doesn't really make sense, is what I'm saying.
So this
Yeah.
person on the right puts her right leg down and pulls the left leg up.
Yes.
Is it going to be normal?
It won't be normal.
That's what he's asking.
Yeah, it will be normal. Do you understand why?
Because it's the right side of weakness, but since it's
Yes.
not.
So if you're not supporting anything, therefore, it's not going to be abnormal. Did everybody catch that? It's a good question. I just don't know if he's trying to trick you guys, that's all. I think he's trying to sabotage the class. But it is a good question. Thank you for explaining that. So, because sometimes, again, I remember it the way I remember it, but it's not important for you to remember how I remember it. It's just important to understand which side is abnormal, right? The side that's abnormal means that it's telling you where the weakness is. Are we good? I'll just keep going so I confuse everybody. But don't worry, we'll hit it again. This is kind of like that specificity sensitivity thing, right? I guarantee there's at least one person in this class that still doesn't understand it. Okay? It's not because you're not able to. It's just because it doesn't make sense, right? The way it's like you say it. Specificity tells you who doesn't have it. That doesn't make sense. Actually, it does, if you think about it. But it just takes a while to kind of turn it around your head and get it straight. Does that make sense? Okay. I don't want to go there again. So, yeah. moving on. So trochanteric bursitis diagnostics. So yeah, you're going to get radiographs, right? Especially in long-standing disease, or sometimes in GTPS, you can actually see some findings. You guys see all those little white arrows? Okay. Does that usually mean that there's abnormalities? Yes, right? So that looks like there's some kind of bony involvement there. Okay. So that can be a sign of long-standing inflammation, because that bursa is there, correct? Yeah. Kind of right around where those white arrows are, at least the ones that are more inferior, correct? Right there and right there, okay? But you want to rule out intra-articular hip pathology. Remember how I told you hip pain can be complicated? Okay, super complicated. And you have to really, and I'll say this again, you got to ask the patient, is your pain anterior, lateral, or posterior? Otherwise, you're fishing. All right, the entire time you're fishing, you're really not nailing it down to a potential diagnosis. So MRIs are rarely needed, but if you have a concern for tumors, what's that diagnosis we talked about? AVN, right? If you have a concern for that, you'll get an MRI, okay? But rarely needed. So especially if they just have trochanteric bursitis, because then it's a focal pain, correct? They don't have any other involvement. You're just treating the trochanteric bursitis, okay? Are we good with that? All right. So outcomes of disease, right? So obviously chronic pain. Can they get a limp? Yeah, limp is bad, right? Limp is bad. But in this case, it's probably a limp secondary to pain, correct? So it's not a weakness, it's secondary to pain. You're going to start documenting stuff like that. Don't worry, you guys will learn to document. Don't just put weakness, right? Put suspect weakness secondary to pain, right? Because when you start writing these consults and sending it to me, I'm like, wait, weakness? And you're sending me a routine consult? Like, have you considered that this could be XYZ, right? So be careful how you write things. We'll get into that more. Sleep disturbances, you think if their hip hurts, especially if they sleep on that side, it's going to cause them to have a change in their circadian rhythm, kind of similar to PA school, right? So treatment-wise, okay, so the good old conservative care. So it's greater trochanteric bursitis. Has an IT band come into play? 100%. So especially in GTPS, correct? If you have tight IT bands, do you think it's going to cause pressure in the bursa? Absolutely 100%. So you want to make sure that when you send them to physical therapy, you write in your consult, I want IT band stretching and hip abduction strengthening. Okay? Those are the two things you want them to focus on. If you guys don't already know, when you guys send referrals to physical therapy, it's not just a referral for right hip pain. Remember when we talked about a long time ago, I told you hip pain or pain, right? Knee pain? That's not a diagnosis, correct? Yes? Okay. So don't just send all your consults for pain. If you write your x-ray orders and just say right hand pain, do you think radiologist is like, due to what? Like, where are you worried about it, right? Because the radiologist is not seeing the patient, correct? So same thing as the physical therapist. The physical therapist has never seen your patient. So if you have a concern, put it in the consult. That's what you're going to write. Focus on IT band stretching and what? Hip abduction strengthening. Make sense? Okay. Steroid injections into the greater trochanteric bursa. I do those very commonly. You know, I know we talk about not doing injections in and around tendons. This is into a bursa though, correct? It's pretty safe, right? You can feel your greater trochanter, correct? Right? So as long as you're injecting into the area where it hurts the most, which patients love, by the way, then it's pretty safe, right? But we do these very commonly, I'm not going to lie to you. So you just put the needle down, get a hip bone, oops, you pull back about 2 millimeters and you start squeezing. Okay, and you inject in that area, and the patient will say, ooh, that really hurts. You're probably doing it right then. Okay, makes sense? Okay. Operative, rare, super rare, like really rare, right? So I've never seen it, but it's possible. So what do? They go on and they take the bursa out. Duh. That's what's causing them issues, correct? Okay. So outcomes of treatment, obviously NSAID risks. Anytime you do an injection, does it have the small chance of infection? Yes. Use sterile technique, right? Referral decisions, So you maximize therapy, you sent them with a good consult to physical therapy, they did all the stuff you asked them to do, the patient's still doing not well, right? Still having significant issues, sleep disturbances, etc., stuff we talked about. Then you refer them for further surgical evaluation, okay? Don't tell the patient they're going to go to ortho and become pain-free. I will find you, okay? Diagnostic uncertainty, you just don't know, right? It's a big constellation of symptoms. You think it's GTPS, but they just got a bunch of stuff going on, okay? Especially if you're concerned about neurologic reasons for a positive Trendelenburg sign. Does that make sense? Like you're like, hey, I can't just figure this out, send it. Suspected fractures, especially if you're suspecting fractures after trauma, send it. Okay? What did we talk about? All these topics. Any questions about these topics that we talked about yesterday in the virtual environment as you were drinking your coffee? No? Okay. At least one person was drinking coffee. Questions? Question? All right, we'll roll right into it, okay? Today we're going to talk about ACL tears, bursitis of the knee, okay? Claudication. You guys love claudication, right? We covered it in so many different classes. Yeah, you love it. I hate it. So collateral ligament tears, specifically lateral collateral ligament and medial collateral ligament. Iliotibial band syndrome, again, a little bit more in detail. Okay, and gastrocnemius tears. Okay, calf tears, correct? We know our anatomy, correct? Okay. So ACL tears, anterior cruciate ligaments. Okay, there are two ligaments. There are four ligaments, that support the knee, right, to provide stability. Two of them are intra-articular and two of them are extra-articular. The anterior cruciate ligament, is that intra-articular or extra-articular? Intra-articular. Okay, we cover that in our MSK radiology and anatomy review. Okay, but the ACL is a primary stabilizer against anterior translation of the tibia, and it also provides stabilization for rotary motion. Okay, does that make sense? And we know this already. Okay. So it's needed in agility sports, specifically running and cutting activities. So like football, for example, soccer. Okay, not straight inline running. So when you ask your patient, do you have instability? Do you think you're going to ask them if they have instability on flat, even ground? No. You're going to ask them if they have instability on uneven ground or when doing twisting and turning and cutting motions, okay? So the way they injure themselves is they get tears from rotational force. It can also have a component of hyperextension or just hyperextension, okay? Especially in more significant trauma situations. But what they normally describe is the plant pivot pop, okay? And non-contact. If you see non-contact knee injury, it's an ACL tear on a PANS question, okay? That is like a buzzword, non-contact, okay? No contact was made. The patient went to plant, they went to pivot, they went to get reverb, and then all of a sudden, it's sudden pain, okay? Are complete ACL tears more common than partials? It's on the slide. They are. And this is a slide I definitely clarified. I hated that whole slide. It was so inadequate. Okay? So, because it's important to understand that in acute ACL injuries, as it gets into there, then you also need to have high suspicion for a medial meniscal tear. You have a high suspicion for a meniscal tear anyways, but the highest association with an acute ACL rupture or high-grade tear or complete tear, right? We understand that that's the same thing now, correct? High-grade, right? Complete, rupture. Those are all the same words. It's just, of course, we say it different ways to confuse people. But if I tell you it's an acute, it's a medial meniscal tear. If I tell you it's chronic, it's a lateral meniscus tear. Those are more commonly associated. Okay? Make sense? No, but you need to know this. Okay? We can get into the biomechanics of the knee, but I'm just telling you for now, I need you to trust me on this because this is proven in literature. Okay? Make sense? Okay? What other things can be associated? Medial collateral ligament injury specifically. They're not as common, but if it's going to be a ligament, it's normally the MCL. Okay? Less common is all this stuff below that. Okay? lateral ligament is complex, okay, otherwise known as posterior lateral corner, posterior lateral capsular. There's all kinds of different ways of saying that, okay? Or PCL tear. So we know that the anterior cruciate ligament is an intra-articular ligament. What's the one that matches it? The PCL, okay? So they can have PCL tears as well. Is that common? No, not common, okay? Do you guys know what the most common way of getting a PCL tear is? Car crash, transport injuries. Now, we'll cover that, but that's correct, okay? All right, so multi-leg injuries, okay, multi-leg knee, super exciting stuff. I love it. It's like 4 to 6 hours of awesome surgery. All right, you gotta fix everything, okay? But they're not very common. If they're present, that usually means you had a high energy injury, okay? So gross instability will be the rule, okay? But the big concern is that they have gross instability, especially if they have posterior dislocation of the knee, they can have a popliteal artery injury. And that is an emergency. That is one true emergency, okay? So is it in red? Mm-hmm. Yes. Okay, so it's body of words on that. I'm not going to ask you about multi-leg injuries. I just want you to know if you have a true knee dislocation that leads to a multi-leg injury, that ortho, do we do vascular? No. So if we're evaluating these patients, we'll call vascular and say, hey, we got an issue here. It's not me, it's you. Okay, this is what you do. Okay, makes sense? So this could be a part of a trauma eval. Okay. All right, so clinical symptoms, like I said before, sudden pain and giving way of the knee due to twisting or hyperextension. Was it contact or non-contact? Non-contact, correct. So 1/3 of patients report an audible pop. They actually say they heard the pop. I've never torn my ACL, so I don't know. Is anybody in here? You have? Did you hear a pop?
Sure did.
So you're one of the 1/3. Congratulations. Okay. So and pay attention to this, I took a lot of time highlighting things. Are they able to continue playing? No. Non-contact, unable to return to play. Okay, we're getting somewhere. Due to pain plus or minus instability. Usually in the acute, right, it just happened, they actually have more pain and no instability. That confuses people, right? Well, guess what? The swelling kicks in pretty quick. So once you get all that swelling in the knee, do you think that they have free motion in the knee? No. So it's actually artificially creating stability, right? But then later on, once the swelling goes down, and especially when they start walking on uneven ground, do they then report instability?
Yes.
And especially when they try to return to play. Okay? So the effusion due to the hemarthrosis can increase the pain, but also give a false sense of stability. Are we good with this definition? Everybody knows that hemarthrosis is blood in the joint, correct? So you rupture the tendons, the ends of the tendon bleed, they fill up that compartment, and they cause pain, okay? And as it says there, instability later, as a patient gradually returns to activities. Are they able to fully return? No. So that'll be when they come back, okay? Chronic knee instability will ensue if untreated. And let's think about this real quick. If you have a knee that's has instability, it's unstable, right? Especially in the anterior translation or rotary translation, do you think that's creating a bit of a mortar and pestle effect again? Yeah, so it's basically grinding down on what? The menisci, right? And the articular cartilage. Everybody sees in this picture here, that's a complete tear of the ACL. Okay, what grade is that? Has an L, right? So that's a grade 3. Would you agree? So how do you think we're going to grade your special test then? 1, 2, and 3. Does that make sense? Okay. We'll get there, I'm just forecasting. All right, so here's your special test. We arrive quickly. So Lockman's test, what's the most sensitive test? Okay, you need to know that. Okay? Because you think if you're doing anterior drawer in an acute setting, especially if they just injured themselves and the swelling is kicking in, that your anterior drawer is going to be falsely negative? Yes. Okay, and it can also be falsely negative because they have a significant contribution from the secondary stabilizers of the knee. So 50% will be false negative. Make sense? 50%. Okay. So we do the anterior drawer, but I'm more interested when you call me on the phone. What does the Walkman's test look like? What does it feel like? If you tell me they just injured themselves and you're unable to get a good exam, I will tell you, good. Document that. Special testing deferred secondary to pain and swelling from an acute injury. Make sense? But when they come back in 2 weeks or a week or whatever, after you send them to physical therapy to get the swelling down and range of motion, then you're going to do your special test, right? Then you're going to figure out, okay, is this real? Make sense? Okay. We'll get into meniscal tears, but I'll just forecast again. I'll kind of give you guys a primer. When it comes to ACL tears, is an ACL tear going to kill somebody? No. Nobody. Did you die again? No. Okay, good. She's still alive. All right. So, but I'm being a little jokey, right? Making jokes, but a meniscal tear, though. Have you guys ever heard of a bucket handle meniscal tear? Yeah, that's a bad thing, right? So a bucket handle meniscal tear, in case you don't know, that's where a significant portion of the meniscus gets torn. It flips into the joint space, and it does not allow the knee to fully extend or to fully flex, or it gets locked in a position. It literally gets locked in a certain position. Then we need to do something, right? Who walks around with their knee bent at like 70 degrees? Nobody? Just want to make sure. Okay. All right, so that's something you need to do something about right away. But with ACL tears, you can slow down a little bit, take a breath, right? Tell the patient they're going to be all right. Right? She didn't die, that patient won't either. Okay? But meniscal injuries, you need to do something about it. Okay, and we'll get into meniscus later. Tuesday, Thursday. Okay, I'm trying to figure out what day it is. All right, so pivot shift test. I will talk about it. I will try to teach it to you. You will do it wrong. Okay, why? It's a challenging test. Okay, if there's any kind of quad contraction while you're doing that test, you won't get a good test. Same thing with the anterior drawer test. If you have any kind of quad or secondary stabilizer contraction, you just won't be able to do it. Okay, so a pivot shift test in ortho, we have our little techniques, and I'll try to show you some of those in the lab. Basically, like look at my hand, or distracting like you do with little kids, right? But it can be challenging. But when we do it in the operating room before we do an ACL reconstruction, then we're like, oh, that's a very satisfying pivot shift test. Okay. So what is a pivot shift test trying to recreate? What does it say there? Rotation. It's trying to assess the ability of the ACL to resist rotation. Okay, but they have to be completely relaxed. Are we good with our definitions for now? Okay, we understand that a Lockman's test is done with the knee in how many degrees of flexion? 20 to 30, correct? I teach it as 30, okay? Right? And an anterior drawer is how many degrees of flexion? 90 degrees. Okay, good. I think we're good. Yeah, I'm feeling good about this. Okay. So diagnostics-wise, obviously you're going to get x-rays. Why do you get x-rays if it's a soft tissue injury and it was non-contact?
Make sure the bulge didn't break. Bulge fracture.
Well, okay. I guess I'll go with X right there. All right, so bulge injuries, right? Other injuries, intra-articular pathology is suggested. But you see that yellow arrow there? What is that called? What is that? If you see that on there, okay, what is that called? Sagone fracture. Sagone fracture. That is not a tibial plateau fracture. Make sense? That is not a tibial plateau fracture. Okay? Did the patient have contact? No. Do normal patients, okay? Somebody will raise their hand, but do normal patients get tibial plateau fractures from non-contact injuries? No. Okay, so don't be that guy or that girl, that lady. Okay? I want to offend anybody. So, but what does it denote? A Sagone fracture is an avulsion of what? The lateral tibial eminence, or we don't more commonly say the lateral capsular margin. So what do you think this is? Is this the eminence or is this the margin? 50-50, 80-20. This is the margin. Okay? Right? It's on the side. Right? So the eminence is going to be the pointing aspect. Okay? Makes sense? Is that important? No. But will this bone fracture, if you see that, sometimes radiologists is lazy, right? They won't even tell, they'll just say there's a fracture. You're like, So you look at it and you're thinking to yourself, oh Jesus, I got to tell you a plateau fracture. Because when you guys talk about that next block, you'll be like, oh my God, I hope I never get a tibia plateau fracture in my clinic. Because that's a big deal, okay? But with these, it's okay to put weight, okay? Because it's not involving a weight-bearing surface, correct? The answer is yes, okay? And it's not significant. But I will tell you, if you see a Sagan fracture, it is an ACL tear. How many times out of 10, let's say, is it an ACL tear complete? 10. 10 times out of 10. So basically what I'm trying to tell you is it's an ACL tear until otherwise proven. Make sense? Why do I say it that way? Are you going to be able to get a good exam on a patient that sustained an ACL tear a day ago? No. You'll get these x-rays, they'll be nice and swollen, right? You won't be able to get a good exam. But you will tell the patient, I have a high suspicion for an ACL tear, specifically a complete rupture, based on the fact that you understand this. That you understand when you see this on an x-ray, that's what it is. Make sense? Have I beat that horse to death yet? Because I can whip it some more. All right. But it's important to understand this, okay? So do you get an MRI right away? No, but you will get one eventually, right? So is it acceptable to get an MRI to confirm it? As the slide says, yes, okay? But is it also acceptable to send the patient to physical therapy and get an MRI? Yes, this is not something you need to sit in your clinic and you're calling radiology, blowing them up, saying he's got to get an MRI now, right? Okay, there you go. And to evaluate for other injuries. What are the other injuries? Meniscus and MCL, correct? Make sense? Because a lot of times patients will come and they'll say, point to me with one finger. Major Davalos told me to ask you to tell me where to point with one finger where it hurts. What's the patient going to do? He's going to say, I don't know, it hurts right about here. Okay? And so that doesn't really give you much information, correct? Make sense? Okay. So ACL tears, of course, you guys, as soon as I put the slide up, you saw it, right? You didn't need the yellow arrow, right? But if you stare long and hard, right? And I changed this slide too, and you look at the difference between the left side and the right side, you would agree that these fibers here appear to be continuous, right? They all seem to be in the same orientation here, right? They're going up, basically laterally, okay, up and down, okay? But if you look at the right side, it looks like someone took a shoestring and cut one end and kind of unfrayed it, right? So it looks frayed. It looks like the fibers are not continuous. Does that make sense? And everybody sees that, right? Of course you do. It's labeled. Okay? So that denotes that there's an ACL rupture. Okay? Sometimes you'll look at it and you'll say, it looks like there's a good amount of the fibers that are disrupted. And I think this patient has an ACL tear. Do they 100% need surgery? No. Remember, the reason to do surgery for ACL injuries, okay, or any ligament injuries, instability, correct? Have I taught you guys that yet?
Yes.
Okay, I hope so. Because pain, is ortho good at treating pain?
No.
I'm good at causing pain, trust me. Especially if you're awake and operating. Okay, but we want patients to tell us that they have instability. It's the surgical indication that tells it. Now they can have pain with instability, but instability is the driving force. If the patient only has pain, they're not a good surgical candidate. Does everybody understand why by now? Okay, because are we going to cause more pain going in there?
Yes.
Yes. Okay, so again, you're going to start asking your patients. So do we treat MRIs or do we treat patients? Patients, right? So don't look at the MRI and look at the report and say you have an ACL rupture, the radiologist says it's incomplete, you need surgery. You'll do it once, maybe twice, and then when the patients come back angry at you because they went to see ortho and they said they're not a good surgical candidate, you'll stop doing it. Okay? All right? Make sense? Okay. All right. Of course it does. So if you don't do anything about it, you're gonna have chronic pain and instability, correct? It can cause subsequent meniscal tears. So just because you have a meniscal tear acutely, do you think it can get worse?
Yes.
Yeah, but you can cause other ones, right? Fraying, degeneration, things like that. And damage to articular surfaces, articular cartilage, and osteoarthritis. Is this primary osteoarthritis or secondary? Secondary. I thought this line on purpose. I'll write it back in. But because I want to see if you guys know that. So it's also, in this case, is it called post-traumatic arthritis? It is. Okay, so this is specific where it's secondary arthritis, you're all correct, okay, but it can also be called post-traumatic arthritis, right? Is an ACL injury a trauma? Yes. Again, hopefully I got you guys out of that mindset that somebody has to hit you with a baseball bat for it to be trauma, okay? Right, so operative versus non-operative, well, the non-operative is straightforward, right? You're gonna send them and do all those things up there. But it's important to understand with non-operative that even if they are operative, and we're gonna do surgery on them, there's three things we wanna regain with physical therapy. That's swelling reduction, range of motion, and strength, okay? For all non-operative patients, that's all they're gonna get, correct? They might get a knee brace, they might get crutches, okay? How long are you gonna leave them on crutches? Somebody get it right. Is he gonna leave them on crutches for 2 weeks? I'll give you choices. All right, 3 days, 7 days, 10 days, or 2 months.
2 months?
2 months? Man, you're brutal. I taught you nothing. So the answer is choice E, none of the above, is you only keep them on crutches as long as they need it. Okay? Because there's really no good answer. So it may be a week, it may be 2 weeks, okay? But basically the shortest amount of time possible. What's the end of your orthopedics? Stiffness. What is one way to actually decrease swelling in the knee, other than putting a needle into it and sucking the fluid out? Motion. Motion is lotion, okay? So getting them moving, right, will actually help pump that fluid out of there. Does that make sense? You ever wonder why your knee just doesn't fill up with fluid? Right? Is it creating synovial fluid constantly?
Yes.
Yes. You ever wonder why it doesn't fill up and then you just, like your leg gets all swollen and dies? Okay, from ischemia? Or is it because there's drainage, correct? All right, good. So hopefully that makes sense. I got all of you on that one. So, can you aspirate the hemarthrosis? Yes. How many times have I done it? I don't even have to teach. So maybe 3 or 4. Honestly, maybe 3 or 4, right? I've done it for multi-legs, don't get me wrong, but for isolated ACL tears, maybe 3 or 4 times. I mean, seriously, less than on one hand, like not very many times. Because is there a risk of infection?
Yes.
100%, right? But am I aggressive about getting that swelling and diffusion down?
Yes.
Yes, okay? So older, less active patients, they will almost exclusively get non-operative treatment. Okay, obviously you're going to try to control stability, and that's when they get that custom ACL brace. Make sense? Okay. So operative, younger active patients, patients that require the ability to do cutting and dynamic motion. Those are patients that we will offer surgery to, as long as there is instability, thank you, 100% of the time, okay? And that is a reconstruction, not a repair. Now, they used to do repairs, so repairs, just to get back into this, repairs is you take what God gave you and you put both ends together, or you fix whatever's there, right? Reconstruction is where you whack whatever's already there, and you take tissue from either a cadaver or another part of the patient's body, and you recreate the ACL. Are we good with that definition? Okay, so an ACL reconstruction more commonly is done than an ACL repair. Make sense? How many ACL repairs I've been a part of? 2. Okay, because again, can you get the same native strength once it's partially torn?
No.
Not necessarily. Okay. So autograft versus allograft. So autograft is you, right? I have to point to somebody. Is you, okay? And allograft is the dead body, the cadaver. Okay, make sense? So which one do you think is stronger?
Autograph?
Autograft. Okay, which one do you think has better ability to heal? Autograft. It's you. You knows you, correct? So those are the complications I'm kind of hinting at with cadavers, is that they're not as strong, okay, and that they're not, that sometimes there's issue with it, what we call incorporating, okay? Incorporation basically means it becomes you, part of you. Make sense? Okay, so there are issues with that. So in younger active patients, we'll often say, hey, we recommend an autograft. If the patient says, I don't want what goes with that, then they get an allograft. Make sense? Am I going to test you on auto versus allo? I'll go ahead and tell you no. But a patient's going to ask you those kind of questions? Yes. So I'm trying to give you at least something to kind of hold on to, okay? Complications, always post-op infection, graft site pain, okay? Do you think if we take part of you from somewhere else, right, that there might be pain where we took that graft? That's what graft site pain is, okay? Failure of incorporation of the graft, I just talked about that. It just doesn't want to become you, okay? Tearing of the graft, parentheses what? Re-rupture. Okay, can you get partial tears of the graft? Sure, okay? But I'm just telling you, re-rupture tends to be more common, okay? So, secondary osteoarthritis after several decades following injury, okay? There you go. That's your adverse outcomes of treatment. Red flags. Patients what? With continued laxity, even if not a surgical candidate, okay? So if for some reason they have continued laxity and issues, we sometimes do injection therapy. Yes, we do other things. Does that make sense? If you feel comfortable doing steroid injections, fine. But if we're going to do surgery, let's get after this right now. Do I want you to give a patient an injection for pain control prior to them seeing me for a surgical evaluation? No. The answer is no. As soon as you stick that needle in and inject that corticosteroid, I gotta wait at least 3 months to do surgery. Okay? So even though the patient's a good candidate and the patient wants the surgery, we have to wait, right? Because anytime you do a corticosteroid injection, it can affect wound healing. Do we want that? No, we want the patient to heal, correct? Good. So gross knee instability, gross, right? Everybody knows what gross knee instability, not sick and disgusting, but meaning like it's just frank. It's frank instability, okay? That means you have a multi-leg injury, correct? That means you could have potentially had a dislocation, correct? Knee dislocation, okay? So what's the artery that's involved? Yes? Okay, popliteal, you're correct. Popliteal artery. So looking at this picture here, we'll see. We'll see where we're at. So is this a posterior dislocation or an anterior dislocation of the knee? And this is not testable. I'm trying to get you guys ready for block 4 because Colonel Sylvester will ask you questions about relativity, meaning how do you describe this? You describe it the femur related to the tibia or the tibia related to the femur? Tibia related to the femur. Okay, so this is a posterior dislocation. Does everybody understand why then the popliteal artery can be affected? Everybody sees here, right? It's behind, right? This is like an oblique view. It's not actually an AP, it's not a lateral, correct? Kind of this weird view that we did probably in the trauma bay, right? I told you guys that a knee dislocation is a big deal, correct? You got a lot of things that support the knee in relation to the femur, in relation to the tibia and the knee, right? So this takes a lot of force, correct? So just to clarify, this is a posterior dislocation because the tibia is translated posterior in relation to the femur. So you describe it based on the relationship of the distal segment to the proximal segment. Does that make sense? So do you think that's how we describe wrist dislocations too? Is that how we describe finger dislocations? Yes. So this concept will be important to you guys in block 4. Good to go? Not testable for now, but just important to understand. Okay? We definitely want to take a break. Some of you guys look like you need more CPR versus AR. Okay? Fancy. So, physical exam-wise, again, tenderness palpation, prepatellar bursitis, excuse me. The actual patella, do you think in this picture here that you can palpate the patella necessarily without much swelling? No, so that's what this is telling you here. You may not be able to actually palpate the patella depending on how profound the swelling is, okay? Pes anserine bursa, okay? If they get a certain amount of swelling there in the medial aspect, do you think there's a branch of the saphenous nerve that curves and kind of courses through that area?
Yes.
The answer is yes. That's why it's in yellow. Which branch? I'm not going to ask you. I'm just going to ask you which main nerve are we talking about. So saphenous nerve branch. Okay, saphenous nerve branch, pes anserine, associated with medial osteoarthritis. Why is it medial osteoarthritis? Because pes anserine is medial, right? Okay, all right, good. Over there. All right, red hot swollen joint, or in this case, red hot swollen bursa, infected, correct? It's in red. Okay, so if it gets bad enough, do you think this patient's going to want to put weight on that top knee there? No, they're not going to want to do it. It hurts. If it hurts, don't do it, right? And there's a picture again, in case you needed it, I added that, of those layers, right? So what you're going to get is you're going to feel that you can actually get to the source of pain pretty quick, right? Because it's superficial. Make sense? Okay. Diagnostics, AP and lateral views of the knee. Okay. Septic bursitis, you aspirate the bursa. Septic joint, you aspirate the joint. Okay? What you don't want to do is that you're suspecting septic bursitis and you stick the needle into there and you go all the way into the joint and take all that bacterial load and put it into the joint. Is that bad? That's real bad. Have I told you guys my story about the guy who got necrotitis fasciitis yet? I did, right? Didn't I tell you that was the elbow? Oh, they can happen in the knee too, right? Does the olecranon have a bursa? It does. Very relatable to this, okay? So if you're going to draw fluid, then you're going to get all the regular stuff. We won't get into that again, okay? Won't necessarily see these kind of questions again on my test, per se. But if you're going to get synovial fluid analysis, please God, understand that you're talking about a joint, correct? For the most part, okay? Make sense? Right. So if the disease progresses, what happens? Well, because of the swelling and the pressure that ensues, you can get deterioration of tissues, right? And that can cause what? Weakening of the surrounding tendons and or ligaments, okay? Chronic drainage, if it's a chronic draining wound, that's bad, right? So especially, what kind of patients get chronic draining wounds? The diabetes. Oh my God, you're gonna love diabetes if you don't already. Okay, and septic spreads to the knee joint. Okay, so treatment-wise, non-operative treatment-wise, I put it in yellow just so it separates the two treatments. Okay, non-operative treatment, is that big, honking, angry, infected? No, that is what? That's going to be something where you think it's non-infectious in nature. Okay, so you can do the regular stuff, okay, the non-operative care. In this case, as the picture shows you there, you can put a compression bandage, okay, to try to compress some of that swelling. It can also provide some relief, right, to the patient. Okay. Now, steroid injections into the bursa. Okay, I put in parentheses there for inflammation, right? And therefore, if it decreases inflammation, because you would agree that it's a steroidal anti-inflammatory, right? Yes. Okay. Somebody's with me. So, if you inject steroids into an infected joint, though, what's going to happen to that infection? It's going to go into turbo, right? It's going to go to 11, right? You don't want to do that, okay? So make sure you have a clear understanding that if you're considering doing steroids, it's not infectious. That's why I separated those categories, okay? But for septic bursitis, what's the rule? Antibiotics of some kind, right? If it's small, minimal, right? Early and mild, those words are all synonymous, correct? Yes? Then you can do oral antibiotics. But if it's more severe, then you do IV antibiotics. When I'm talking about IV antibiotics, do you think the patient is at least in the emergency room, if not in inpatient setting? Yes, right? So this is not something that you're going to be playing with in clinic, right? Necessarily. Depending on some forward-deployed areas, we've done IV antibiotics in our clinic. It's really not a clinic, it's a troop aid station, right? Battalion aid station, et cetera, et cetera. Everybody understands the difference between non-infectious and infectious treatment. Infectious, again, being more appropriately termed septic. Okay? Good to go? Have you guys heard the term aseptic before?
Yes.
Is that infectious? No. So we're still talking about the same things, right? Okay. So operative, what do? If the deed needs to be done, we take it to the operating room, we put the patient to sleep, and we drain it, and we excise. Okay, we take any non-viable tissue. That's why it says excision there, right? Often not required though. Only in the cases of infectious, correct? Okay. So what does that tell you? Does that tell you that more commonly it's non-infectious in nature? Yes, very commonly you'll see this. Did we talk about nursemaids over here? Overuse of nursemaids. Housemaids, not handmaided, right? Housemaids, right? So this can be something that you'll see and you'll get a history of overuse, et cetera, et cetera. But if you have a puncture wound around the, I'll get there eventually, around the wound itself, you're highly suspicious for infection, right? Okay? All right. These are your referral decisions. Obviously, anything titled septic is bad. Call somebody. Evidence of ligament or tendon insufficiency. Call somebody. What's in red there? If they keep getting these infections, you got to send them. Is there something else going on? Make sense? You're missing something? Or do patients sometimes have MRSA? Yeah, so they just keep, their nasal passages, their nares are colonized with MRSA, right? And so they just keep getting these chronic infections. Make sense? Because they may require operative treatment to clear the infection. Okay? There you go. Okay. Claudication. I don't know about you guys, but this isn't one of my favorite topics. Neurogenic, maybe, I'll take it. Vascular, not me, right? But I think it is important for you guys to know this because this is important, right? Because vascular claudication is something you cover in other courses, so it's thrown into my course because neurogenic claudication is part of it. Good to go? So in an effort to kind of break it down a little bit more, I have provided these definitions for you guys. Are you going to see any questions on my test about this? Maybe, but it's going to be broad strokes, right? Because I'm not the vascular guy. Does that make sense? So, did we already test on spine? Do I test you on the same topics over and over? No. Things like osteoarthritis? Yes, right? It has to keep going, right? It never ends, okay? But claudicated, neurogenic type stuff, neuropathies, kind of already covered that, right? But I do think it's important for you to take a look at this because this chart here is pants fodder, right? It's like a buffet, right? There are so many questions that can come out of this slide. Okay, do you understand how neurogenic differs from vascular? Okay? And again, with this slide here, do patients with neurogenic claudication get ulcerations or wounds that won't heal? No. It says it right there. Vascular patients do. So they love to ask you questions like this. Make sense? Okay, so I do think it's important for you guys to learn this. I'm just not necessarily going to beat you over the head about this. Let's do more ACL type stuff, okay? What is neurogenic claudication? So as it describes there, right, you're going to have to, it's spinal canal narrowing, correct? So there's some kind of compression because of the narrowing, right? So are you going to have to do a bunch of imaging studies? Yes, those are covered there again. On the vascular side, what kind of studies do you do? Well, you do vascular studies. Do you guys know what ankle brachial index is? Everybody in this room, if I asked you to right now, could do an ABI, right? Yes. The answer is yes, please. It's being recorded. Okay? But the reality of it is, I'm not going to go through that with you guys because it's not, do I do those in ortho? Sometimes, especially in trauma. But we don't do those like in a routine clinic visit. Does that make sense? All right, so this is something that's better taught in different courses. But do I think it's important for you guys to know that 0.9 is abnormal? Less than 0.9 is abnormal? Yes. So I think that's fair game. Okay, because could it be part of like a scenario I give you where I tell you basically what maybe like a multi-leg injury, right? Could it have an abnormal ABI? Okay, makes sense. So 0.9, less than 0.9, I want you to know. Okay, if it's 1.0, is that normal? Okay, so you guys understand, again, nobody got it wrong for the first time in a long time. Okay, but more negative is negative, right? And more positive is positive, right? Draw a picture if you have to. But just understand, less than 0.9, is that normal or abnormal? So if it's 1 point under, 1 tick under, 1 fraction under, is that abnormal? Yes. Okay, good. All right, so Doppler ultrasound and arteriography. That's about what I want you to know with the imaging studies, okay? I want you to be able to categorize these at least, okay? So the important thing to understand too is that arterial insufficiency, is that bad? Yes, because ischemia can lead to limb loss. Do we want patients to lose limbs? No, not on purpose, okay? So treatment-wise, yes, there's things like meticulous foot care, well-fitting shoes. You guys will cover that in block 4 when you start talking about footwear, correct? Yes. I know you guys have looked ahead already. But do you want to use elastic support hose in the case of vascular claudication? No. It's in yellow. Okay, gotcha. Okay, because you think so, right? But you actually use elastic band, and you're okay, you're fine. I did that on purpose. But elastic support hose, that's used for venous insufficiency. This is arterial insufficiency, correct? So if you have ischemia and you put more compression on it, will you cause more ischemia? Potentially. So again, your book even says it. I didn't pull that out of thin air. Your book says it, right? Do not use elastic support hoses. That's venous insufficiency, okay? Is it life-threatening? Yes, that's also in yellow, correct? You're welcome. Okay. So neurogenic claudication, still not me. And it's ortho spine, right? Or neurosurgery. We talked about that before. Vascular, definitely not me. That's vascular surgeon, right? Okay. So there you go. That's your referral decisions. Call someone else. Okay. Good to go? Any questions about claudication? I want you guys to take it seriously. I provided those slides and those supplemental slides on purpose. That way you have a reference to look at, okay? But it doesn't necessarily have any play in my tests because I only have 50 questions to ask you 49 questions about ACLs. Okay? Does that make sense? Okay. Excuse me. All right, so we're going to talk about collateral ligament tears, okay? What are the 2 collateral ligaments?
Medial, lateral.
Medial and lateral, right? And then are they intra-articular or extra-articular? Okay, good. We can pick up a little speed then. All right, so those are extra-articular. So, but medial collateral ligaments, is that caused by valgus or varus force?
Valgus.
Valgus. Blow to the lateral knee. Okay, think about this for a second. Blow to the lateral knee with a planted foot. Do it real quick. Is that causing a valgus or a varus force? Valgus. Okay, so people get confused because they just read the words, but they don't think about the force. Because this is actually showing a force, correct? Was I a nice guy and provided you this slide to explain it a little bit better? Yes. You're welcome. Okay, so lateral collateral ligament, that is a varus force, right? Now, the words adduction and abduction are in there as well. We don't use those. That's for other people. But I put it in there because your book mentions it, okay? Which one is more common? We talked about it, MCLs, okay? And it even says there, lateral collateral ligament injuries are uncommon, okay? If you have a lateral collateral ligament injury, is that very commonly associated with posterior lateral corner injuries? Yes, we talked about it. I listed those structures there. I want you to kind of know those, but those aren't necessarily like you have to know those, because can you tell which one of those is injured based on a physical exam? No. Are you gonna have a significant amount of instability? Yes. Are you gonna get an MRI? Yes. The one thing I do want you to take note though, you guys have talked about foot drop before, right? Which nerve is foot drop commonly associated with? Injury to the peroneal nerve, okay? Peroneal nerve, makes sense? Does the peroneal nerve kind of course through there and go lateral?
Yes.
The answer is yes. Doesn't matter what you said. Okay. So collateral ligament tears, there's your explanation of those forces. That's fair game. And not just in my course, but in the world, right? Because how are you going to describe, are you going to ask the patient, excuse me, to describe their mechanism of injury? Then they're going to tell you the force that was applied. Does that make sense? They took a helmet, a football helmet, to the lateral aspect of their knee. So therefore, they have a valgus force. Make sense? Okay. I'll get one of you. Okay. Not on purpose though. So collateral ligament injuries. So can they return to play? No. Okay. This is not an ACL injury, correct? I got at least one person. Okay, so they can return to play. But they will have swelling and stiffness along the affected ligament, decreased motion in the first 6 to 8 hours. So again, initially they may be just fine, right? But then what does it say there? After 24, 48 hours, they'll get that localized ecchymosis and a small effusion may develop, okay? If you see a large hemorrhagosis, even if you're thinking it's a collateral ligament injury, it is always an ACL or PCL injury until otherwise proven. Okay, pause for effect. Large hemorrhagosis, ACL, PCL injury until otherwise proven. Don't forget that for pants. Okay, they'll try to throw you off. They'll write this like 2-paragraph question. As soon as you see large hemorrhagosis, understand what the question is asking you, choose the right answer, and move on. Okay, if they have mechanical symptoms, you're suspecting what? Meniscal tears, meniscal injuries, right? So especially if they have, what's it called, a catching and locking. You guys know what catching and locking, right, is? Catching is where they literally, the meniscal tear, the flip component of the meniscus is catching as the knee is being flexed and extended. Locking is where they get to a certain position and they're locked into that position because the meniscus is causing that lock. Does that make sense? Can they go from a catching to a locking to a locked position to then an unlocked position? Yes. So if I get a call from the ER and says this patient has a bulky handle tear in the meniscus, and I come down and I say, okay, give me 10 C's of lidocaine, numb them up, right? I'm not a total monster. And then I do the maneuver, and we'll go through. You guys know what McMurray's is, right? I basically do the opposite of whatever side is flipped. Does that make sense? So if it's medial, I do a lateral McMurray's. But anyways, I unlock it, okay? So understand that if the patient has these mechanical symptoms, even in the setting of a collateral ligament tear, it is a meniscus injury until otherwise proven. Make sense? Okay. Physical exam-wise, always, test one side and compare it to the other. You guys remember varus and valgus stress testing is 0 and 30 degrees? Okay? 0 degrees is fully extended. 30 degrees is 30 degrees. I can't jump fast enough. So laxity grading. So we talk about grade 1, 2, and 3. There it is. Millimeters, right? What width is the average fingernail? Small fingernail width? 10 millimeters, 1 centimeter, correct? So 5 millimeters is not very much, is it? So do you think sometimes even when you compare both sides, you're kind of thrown off? Yes. Okay, especially if the patient is loose, right? Normally, not in character, in ligaments. Okay. All right, I keep using that joke. So LCLs, you want to evaluate for what nerve? Okay, there it is in yellow. So I've said it twice, mentioned it, it's in yellow. Good to go. Okay, deep peroneal nerve versus superficial peroneal nerve. You guys know this, right? You guys know that ankle dorsiflexion strength is related to the deep peroneal nerve, right? I don't want to harp on this. Okay, we already did our neuro, run with it. But I would know, if you don't know these things at the bottom, you need to know these things, okay? So you guys see there my little explanation again of those forces, okay? Valgus and varus. Okay, we talked about varus and valgus already with the elbow, right? Yep. Some of you guys remember. So now this breaks down. Okay, now we talk about specific. We were just talking about collateral ligaments. Now we talk about MCLs when it comes to radiographs. When it comes to radiographs, and you talk about MCLs, well, it's the medial collateral ligament, right? So you're looking for pathology on the medial aspect of the knee. Okay, you're going to get AP and lateral views, and you're going to see what? Avulsion fracture at the femoral origin. Okay, do you think that's good? No, that's not good, right? But that's what you're looking for on these reviews, okay? Because that is an indication that this could be a pretty significant injury, right? Will you get an MRI? Sure. You guys appreciate I gave you guys not only the x-rays, but some x-rays with some MRIs that kind of show some of the pathology, okay? MRIs, believe it or not, after you look at enough MRIs, you'll see it, I promise. You probably only see it now because of the white arrow, but in the future you'll be like, well, that just doesn't look normal, okay? Does that look kind of like stretched, stringy, kind of wavy right there? Okay? So, yeah? You believe me, yeah? Okay, so that's what we call that the string sign. It looks like something's been stretched out, kind of relaxed, and then it's kind of wavy. Make sense? So we call that a string sign. So it looks like that ligament's been injured. Okay? Good to go? And then are you always going to be suspicious for ACL and PCL injuries? Yes, you're going to evaluate. Okay? Now, when it comes to LCL, remember I told you guys already some MSK rheology review that on the medial side, right, it goes from one condyle to the other as far as the ligament. But on the lateral side, the ligament goes from the femoral condyle to what? The fibular head. Make sense? So don't let that throw you off. Know your anatomy there, fibular insertion. Okay, because that's what you're looking for. You guys see this area here where it looks like that bone's been pulled off? Okay, by definition, that's an avulsion, right? So that's what you're concerned about. So, and if you see this, you're suspicious for an LCL injury, and by that nature, also posterior lateral corner injury, right? Plus or minus PCL, but PCL again doesn't really come into play here. So, you guys see that wavy sign there? See how those kind of stringy there? Not even one, yes? Okay. All right, you'll see it eventually. Okay. All right, but treatment-wise, good gosh, there's a lot going on here, right? Let me just go back here. There's a lot going on this slide, okay? So I want you to know absolutely 100% all of this. Not necessarily, but you see how there's some things that are worse than others. So a grade 3 MCL that does not involve a tibial avulsion, I can't stand anywhere near here. Is that something you can treat non-operatively? Yes, because if you look up here, it's up here, right, under non-operative. But if you go down here and it says tibial avulsion in the MCL, is that operative? Yes. Okay, so you get an MRI, you get a report, you see this, or do patients sometimes just present to you with an MRI and a report, and they injured themselves like a month ago while they're on vacation, and they got seen in Guatemala at some clinic somewhere and paid like 7 cents for medical care? Yes. Okay, and then TRICARE paid $5,000 for an MRI. It happens. True story. And they just walk in and you say, hey, I got this. And you look at it and you're like, holy sweet Jesus, you got a tibial avulsion of the MCL. Is that something you need to call me about?
Yeah.
100%, okay? And tell me the story about the Guatemala thing too. But otherwise, if you look up here, it's pretty conservative stuff, right? Grade 1, 2s, right? NSAIDs, rights, activity modification, physical therapy, right? Crutches and a hinged knee brace. Does anybody not know what a hinged knee brace is? I'm trying to get some DME, some durable medical equipment here so I can like hold it up during the lectures. I think that's valuable. But basically it's that brace you've seen people that has a hinge on it. It's not just the knee sleeve, it's the whole thing. It goes from about the mid thigh all the way across the knee down into the potentially the calf muscle, calf region, right? And then it has like a mechanical looking hinge on it. That's why it's called a hinge knee brace. Are we good with my terrible description? Okay, but that's not a knee sleeve, correct? Okay, all right, good. So how fast will they return to play? About a month with these three up here. Okay, is a grade 3 MCL not including a tibial avulsion though? Is that something you still need to slow them down a little bit more? Yes, right? So how long do they take to return? 3 to 4 months, unless you're Adrian Peterson and then you just come back next week, right? All right, because you're like Superman. Okay. Yeah. So, and again, the treatment down here, it gets into it again, LCL type 3. grade 3. Okay, complete LCL, PLC, you think you're gonna need surgery? Posterior lateral corners PLC by now, right? All right, okay, good. That's it. I gotta stop. You guys are killing me. All right. Any questions?